My name is Neville Hacker and I have been running the Gynaecological Cancer Centre at the Royal Hospital for Women in Sydney since 1986. One of my major objectives when I came back was to set up a multidisciplinary team. Over the next 3 or 4 years I managed to get a lot of that team together, including Professor Michael Friedlander, who along with myself has been a past president of the IGCS. We've always had a strong focus on the patient. We have a weekly meeting at which each inpatient is discussed by members of the multidisciplinary team. We have a lot of expertise in different areas within that team, and they each bring a lot of passion to the discussion, and I think this highlights the issues involved and makes for a resolution of often very complex and challenging problems.
I think what makes the Royal Hospital for Women different to other centres around the country, and in fact possibly many other places around the world, is the fact that we have a very collegial, cooperative group of people working together, specialising in the field of gynaecological oncology. We work very closely together for over a quarter of a century. We have been collaborating in many different aspects of management, and I think the difference about this unit is that there are multiple individuals, all who bring special levels of expertise, including surgery, medical oncology, palliative care, genetics, supportive care, etc., which makes us quite different, also with very supportive and expert nursing support.
Radiation oncology is a very important part of a gynaecological oncology service. We use radiotherapy in many patients, sometimes after surgery, sometimes on its own as a definitive treatment, or in combination with chemotherapy. Some patients, in fact, have all 3 modalities of treatment. Most patients are treated with curative intent. Some, however, have more advanced disease, and radiotherapy can be a very useful part of their palliative management as well. So one of the things that we do slightly differently here from many gynaecological oncology centres is we make more use of the combination of surgery and radiotherapy for stage 1B cervix cancer. The traditional teaching has been that you should try to use one modality or the other to avoid the complications of both. However, here we've had very good results using surgery for the larger stage 1Bs and then following that with small field radiotherapy rather than the traditional large post-operative fields. So as you can see here, on the left is the standard post-operative field covering the pelvic lymph nodes up to the level of L4-5 and including a significant amount of bowel. However, if the patients had the pelvic lymph nodes removed and they were clear, there's really no need to treat that area. And so we now use a small central pelvic field with a lower upper level and narrower borders at the side. As you can see, most of the bowel is no longer in the field, but you're just covering the central region where you're most concerned about disease recurrence. And this is very well tolerated, both acutely and in the long term.
So at the Royal Hospital for Women we have 2 accredited training positions. We usually take 1 trainee from Australia or New Zealand who participates in our usual gynaecological training program over 3 years. We also make an effort to take an overseas person, particularly trainees from developing countries, to learn the techniques, the surgical techniques, and how we look after women with gynaecological cancer here in our unit in Australia. So at the Royal Hospital for Women we benefit from having 2 accredited trainees. Our own trainees are of a very high standard, and the overseas trainees teach us to be very culturally diverse, and so it's a mutual arrangement, and we benefit by having them teach us how they would manage cases overseas in a different environment, and they take back with them some of the surgical and clinical skills they otherwise would not have learnt in their own country.
We have been very much the cutting edge of research in gynaecological oncology in Australia at the Royal Hospital for Women. I was the founder and initial chair of the Australia-New Zealand Gynaecological Oncology Group. We've been running clinical trials here from the day I started, and these are cutting edge trials that really changed the way that we manage women with ovarian cancer specifically, but also other gynecological cancer types. And at the moment we're focusing mainly in PARP inhibitors and in immune checkpoint inhibitors.
There is a strong culture for nursing research in the department, and this is very well supported by Professor Hacker and by nursing administration. So most recently, a part of my PhD research has been looking at the trends in incidence and mortality for vulvar cancer in Australia over the last 30 years. And overall we found that there's been an increasing incidence in vulvar cancer for women under 60 years of age. And this is probably most attributable to their exposure to the human papillomavirus since the 1950s. We are also looking at the presence of p53 mutations in squamous cell carcinoma of the vulva, and this immunohistochemical profile may be beneficial in determining disease progression and prognosis in the individual patient with vulvar cancer.
Women that have gynecological cancer suffer a lot of side effects from their surgery and their treatments, that being radiation and chemo. And these are the sorts of things that I deal with and help them with. A lot of that is anxiety and depression. One of the biggest problems I find is fertility, because we do have very young women come in here as well who've got to have all their reproductive organs removed, and therefore they can't have children, and that often causes the most extraordinary grief. So I do spend a lot of time with those sorts of problems in women. I think the uniqueness of this centre is that we are able to actually diagnose patients, treat patients, and take them right through to maybe palliative care. And we do all that under the same roof. And I feel quite privileged that I'm involved in that care, that long-term care.
The most challenging cancer that we treat is ovarian cancer, and it's challenging because it's so difficult to diagnose while still confined to the ovary. So for the last 15 or 20 years, we've had a basic research program aimed at trying to find a screening test, a marker, or more likely a panel of markers that would allow population screening. This is really the holy grail of gynecological cancer research, to discover a screening test for ovarian cancer. Uniquely, I guess, one of our major interests has been in the surgical management of the stage 1B2 cervical cancer. These are the big cancers confined to the cervix. And two of the cases that we reported were actually pregnant at the time, and they had radical caesarean hysterectomies. But more recently, we had a young woman, Lisa, who elected not to have the surgery, although she had a very large 1B2 cervical cancer at about 18 to 19 weeks. We got Michael Friedlander involved, and she had some chemotherapy and had a remarkably good response to the chemotherapy. And she subsequently had a successful caesarean radical hysterectomy, and the baby's doing very well.
So I guess in a nutshell, the hospital staff were just outstanding, and we couldn't fault it, going from oncology to birthing suite, and you know, from the reception staff and the professors and every single person that I have ever met here and continue to meet and catch up with on the outside world. It's like another life. Like, I feel like royalty when I'm here, and I'm just so ever grateful that I stepped foot in this hospital. Yeah, I really am.